Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
DJ Wilson, part of the team here at State of Reform that brings you some of these conversations at the intersection of left and right, public and private, and we're super excited to host this conversation again today, where we have some of the smartest people on the topic of prescription drug pricing, regulation, cost control, really in all of Texas, but also all of the country. So we have invited a number of our folks that read our Texas newsletter and who attend our Texas events, but we've also invited folks from across country to sit in and participate on this conversation. So before we jump in, I want to give you just a little bit of a logistics tour here about how things will roll and how you can engage with us. This frame of 5 slides we're watching is a set of 5 topics, 5 slides we're discussing rather, are a set of 5 slides and graphics that sort of exist in this multimedia place in which we all live. And so each of our guests here have brought one slide with them to highlight what they think are the most important topics or the most pressing challenge when it comes to our topic today and controlling prescription drug costs. And so we'll spend a few minutes on each of those slides, really digging into what they think are the most pressing topics and the most interesting things commanding their time share, or their mind share rather. So as we do that, I want to encourage you all in our audience to engage through this chat box on the right. You can see it there, and I'm going to sort of write a few things here as we go on throughout the show. And when folks pose a question that you would like to have answered, just go ahead and prioritize it. There's a little thumbs up button, and you can click that thumbs up button to prioritize and move those questions up. That way I know which ones more folks in our audience are interested in hearing about, and I can make sure those get integrated into the conversation. And then finally, of course, this will be is being recorded, and your questions will not be recorded, but the video will be recorded, and we'll put that out on our State of Reform site and distribute it throughout our Texas readership, and of course post it on our site for everybody to see and to watch afterwards. So without any further ado, now we got that sort of administrative work out of the way, I want to jump into a quick round of introductions and start first with Congressman Dr. Michael Burgess. Dr. Burgess, thanks for making time to be with us. We got you on mute, sir. That's part of the challenge of time.
State of Reform is on mute. Thanks for having me.
Yeah, thanks for being here. We also have Dr. Wayne Weingarten, who this is a little bit of a mouthful, so pardon me, the Senior Fellow and Director at the Center for Medical Economics and Innovation at the Pacific Research Institute. Wayne, thanks for making time.
Well, thanks for having me. Appreciate it.
Yeah, do you want to just tell us real quick about the work you do at the Pacific Research Institute?
Oh, absolutely. I'm, like you said, a Senior Fellow, work on numerous issues. One of my priorities is as the Director for the Center for Medical Economics and Innovation, where our goal is to focus on how do we get a healthcare system that promotes both innovation and affordability. We focus very heavily on drugs and other medical devices, and try to talk about reforms that increase the affordability, right? Make drugs more affordable for people, but also maintain the incentives for one of the most vibrant sectors we have in the economy, both for future cures, but also for current economic growth.
Yeah, great. Thanks, Wayne. And Annette Gorisco Fildes, thought I was going to mess that up. I think I got it right. President and CEO of the ERISA Industry Committee. Annette, thanks for making time. Tell us about the work that you're doing at the committee.
Thank you so much. Such a pleasure to be here. So the ERISA Industry Committee is a trade association that's nationally based. We represent employers in every industry sector. You engage with them every day when you drive a car or fill it with gas or use a cell phone or a computer or go to a bank or a hotel or fly in a plane, whatever, you get the picture. So our member companies have nationwide workforces, and we lobby for federal and state rules to help them be able to provide great health and retirement, paid leave, and other benefits to their workforce. So we try to make things easier for them, and so that they can cost effectively do as much as they can for their workforce, because they're innovators when it comes to providing great wellness and terrific benefits for their workforce, securing their mental health and financial well-being, and et cetera. So we do a lot of lobbying when it comes to drug costs, and we think that there's opportunity for lower costs for everyone, along with providing great innovation and tools for patients across the country.
Yeah, great. Thanks, Annette. I want to jump right into our first slide, and this slide is really just a screenshot. It's one that I've brought. It's really just a screenshot back from February 2nd, 2020. That is in the before times, before COVID, and at our last Texas conference that we hosted on February 2nd, 2020. Congressman Burgess was one of our keynote guests, and he, in February, before COVID had fully enveloped us and before it had sort of taken over some of our policy and politics, this is what Congressman Burgess had to say.
The other thing that I didn't mention, and I apologize about this, but overshadowing everything that we're talking about is this damn coronavirus. And I will tell you, having been in Congress through SARS, through bird flu 1, swine flu, bird flu 2, Zika, and Ebola, I'm as concerned about this one, more concerned about this one than I have been about any of those other episodes of public health crises that we've faced. The numbers that I'm hearing, and I'm sure they're not up to date, but it went from 7,000 cases last Thursday to over 20,000 cases by Tuesday. That's a tripling in 5 days. The lethality rate is not as great as with SARS, but the infectivity seems to be easier, more facile, and the individual-to-individual transmission of the virus is one that all of us should be very concerned about. And the other thing is the possibility, I don't know whether it's been absolutely proven yet, but the possibility that someone can be infective before they're symptomatic. And that really raises some serious concerns.
So that was Congressman Dr. Michael Burgess back in February of 2020. And Dr. Burgess, I know you couldn't hear that clip, but you said that one of the things that was worrying you the most was this coronavirus, and that you were concerned about it, and that you expressed the need for policymakers to get our hands around this, not just in terms of maybe controlling it, but really understanding, which back in February of 2020, we didn't have a lot of understanding about the virus or the disease. I want to just ask you first, sir, how has this first year of COVID life been for you, both as a policymaker and personally?
Well, again, thanks for having me on, and thanks for the nostalgic trip to February 2nd, 2020. Life seemed so much simpler then, didn't it? Look, no part of American life, or really nobody on this planet has had an easy time with the presence of the coronavirus in our midst. I guess the thing I'd have to go to today is just the absolute miracle to have not one, not two, but 3 vaccines that are highly effective now available and being given. In fact, in Texas, I think we just got the word that anyone now above the age of 18 is now eligible for the vaccine. So I encourage people, when it's your turn, get the vaccine. It's our way out of this coronavirus tyranny, but it has been hard. It's affected so many things, and I think back to a year ago, the Trump administration had risen high on the economy, and there were so many more people who were now insured by ERISA-sponsored plans. I've never got the correct numbers out of the Congressional Budget Office, but I believe it was in excess of 4 million more people had jobs and had or at least access to employer-sponsored insurance. So that was a tremendous course we were on, and then it was all decimated by the coronavirus.
How has this year, impacted you personally, Congressman, in terms of just, I'm sure you didn't see your grandkids maybe as much as you would have liked, or, some of those things. Were you able to get out and see constituents? How has this changed things for you?
Well, it's been, as you know very well, you really couldn't do the types of things you were normally used to doing. It was an election year, so that made it additionally hard. Right. We've got our first, on a personal level, we've got our first time with our grandkids coming up weekend after next, Easter weekend. We'll see them for the first time in literally a year. So both my wife and I have had both of our shots. We're feeling more comfortable about seeing other people, but it's been a year of living a solitary life, hasn't it?
Yeah. And how about you? What has this last year been like? When you talk about this, when we're all old and gray, how will you talk about this year of 2020?
Well, I think it's been a year of sacrifice and adaptability. I think you can handle it if you're willing to kind of roll with the punches. Wait patiently and in line for your turn to get a vaccine. I just got my first one, so I'm pretty excited about that. And I think that I guess what has struck me, frankly, is that no matter where you are in the country, big city, small rural town, no matter who you work for, big business, small business, you're all impacted by it. And there's been these great opportunities across the country for people to help each other. And I think I'm hoping that that's the one thing that leads us forward is a sense of community and supporting each other. You know someone who got COVID, you rally around to help them. And I think the other thing is recognizing this real strain on our healthcare system. I mean, just think about the hospitals and the hospital workers and the emergency medical people who have had to, work through all of this and not see their family and, throw their clothes outside in the garage before they go home. It's really just quite challenging. And we have a system that needs support. And I hope that we, can rally around that as well.
Yeah. How about you, Wayne? When you think of this last 12-month period, what are the things that stand out from your personal experience?
From my personal experience, I guess I would go with the idea of fortitude. Having kids in high school and college, and having to get through those issues and manage, and certainly not the life cycle events that you expected, but you manage what you're given, not necessarily what you want to happen. And I think that's probably the most important going forward. We need to reflect and learn lessons. There's a tremendous number of lessons, whether it's health policy, economic policy, budget policy. I think there's personal finance, all the way down the road from the macro to our individuals, that we really, as we're seeing that light at the end of the tunnel, and let's hope that we are seeing it and it's not an oncoming train, that we need to take stock of that and take away the right lessons so that we've grown from the experience, as opposed to not be prepared, with what could possibly come next.
Yeah. So Dr. Burgess, is the senior physician in Congress, you've got kind of an outsized role in terms of health policy, particularly in your caucus. I want to turn first to your slide titled "The Drug Cost Implications for Medicaid Programs." Tell us what you have going on in this slide and why you brought it to the conversation.
Well, the reason I brought it to the conversation, I don't know if you recall, right at the end of 2016, we passed a really big bill called Cures for the 21st Century. It was an important bill, and the idea was that we would get these groundbreaking cures to people faster, and more people would benefit. And right before that bill came for its final vote, Congressman Bobby Rush of Chicago, came up to me and he said, "Doc, we didn't do anything about sickle cell." And the purpose of the Cures bill wasn't really disease focused. It was more on the research and how do we get things through the phase 1, phase 3, phase 3 trials faster and go from the laboratory bench to the bedside faster. But he had a good point. And as much as we had done in the Cures bill, we really hadn't moderated the course of sickle cell disease. In fact, further looking into it, it had been 40 years since there'd been a new FDA-approved therapy for sickle cell disease. Now, during the last 4 years, there's been a lot of work done, and some really intriguing work on, sickle cell results in from just a single spelling error. One base pair is wrong in the gene that encodes for the production of hemoglobin, the the part of our red blood cells that carries oxygen. And because of that spelling error, the cells can disfigure and lose their shape and take on a characteristic sickle shape, which is where the name of the condition comes from. By taking a little tiny part of the AIDS virus and taming it and utilizing it in a special way, you can actually correct that spelling error. And in fact, that has been done. Now, it's time consuming, it's difficult, it's hard on the patient, and clearly there is an outsized cost associated with all this. But the bottom line is, it's one-time treatment and then it's done. That person is cured of that dreadful disease ever after. So if you look at the cost, you go, oh my gosh, that's too expensive. You couldn't possibly do that for an individual. But then I also come back and ask, what was the cost of doing nothing for 40 years? And the people who suffer with this disease suffer massively. They have painful attacks. Their life expectancy is shortened. They have an outnumber of strokes. Kidney disease is a problem. There are a whole host of additional medical problems that occur. And if you fix that, what have you fixed downstream? So the whole idea is that the cost of doing nothing is very real. And if you amortize that over 40 years, you might find that the cost of therapy, in fact, would be less, not to mention the benefit from increased productivity. So the whole idea here was to allow, HR 19 was a bill that we offered in the fall of 2019 that would allow states an option to have Medicaid coverage, and again, prorated over a longer period of time, to allow the states to be able to afford this type of groundbreaking therapy for their patients with sickle cell disease.
HR 19's focus on value-based care and payment models reminds me that I am remiss in thanking Signify Health, one of our sponsors. I was jumbling around at the top of this show, and I want to just say thank you to Signify Health for sponsoring and underwriting this, so that we can make sure that we have these conversations that are free to everybody who participates. So thank you. So, Congressman, tell me a little more about what you call the Lower Costs, More Cures Act. It's focused on state Medicaid flexibility, and tell us how you see the federal government trying to help create flexibility for state Medicaid plans, particularly in the RX space.
Well, and when you go back to the Cures bill, we will do another version of it, Cures 2.0. And what I have asked us to focus on is not just the cures, but how about the affordability of the therapy? Doesn't do any good to have a breakthrough therapy and then not have it available for anyone. And these types of groundbreaking therapies, sometimes a single therapeutic interval will fix the problem for a person's lifetime. And again, how do you amortize that over the time span to actually allow for basically to fund the research that was necessary to get you there in the first place? So the last thing you want to do, and especially this year, we've seen it up close and personal with the advancements in science and how nimble science can be. You certainly wouldn't want to do anything that would hinder that agility. But at the same time, you also recognize that you do have to do something to ameliorate costs. But look, when I think of this, this is not like producing the next nausea drug or the next ulcer drug. These are groundbreaking therapies that will have a profound effect on someone's life. And again, sometimes it's a one-time administration for a lifetime that is now restored health. And how do you amortize that in the appropriate way? We've seen some examples of states using in Medicaid the flexibility to use it's called the Netflix model. So you basically subscribe and then the incidents are covered. This was what came up during the hepatitis C when the cure for hepatitis C was now available, but now very costly. Allow states the flexibility to use that type of subscription model for their hepatitis C patients. It may or may not work, but the key is we've got to do something different from what has been done historically. Otherwise, we're going to end up where payors, like our friends who sponsor employer multi-state insurance plans, are not able to afford what they have been historically delivering.
So Annette, he tees that up for employers like those that you represent. What do you make of this slide? And particularly, I'm wondering how you think that innovations in Medicaid policy might affect employers.
Well, we're always pleased to see the government being innovative in how they pay for healthcare services. The value-based model, we think, is really the model of the future, rather than fee-for-service, where practices will just be paid for visits and things, as opposed to an episode of care or entire treatment. Self-insured employers, like our member companies, have pay, typically my companies pay at least 80% of the cost of healthcare coverage for their workforce and the families, and often retirees as well. That's a big nut. That's a lot of money that they pay. And they need to amortize, to use the congressman's word, the cost of that. They need to spread the cost of that over their entire workforce. So it's important when we look at these therapies, certainly like gene therapies of the future and things, they are very, very costly. Rare disease drugs also very costly for a small population, but they're important because we need to improve those lives for those patients and their families, but we need to figure out a way to spread it all across. We think the answer to all of this is competition. Hard when you're the first out of the box and you haven't yet gotten your full patent protection, but when the patent's expired, we need robust competition after that to lower the cost for everybody.
So Wayne, I want to spend time in particular on this question of competition and what that looks like in healthcare in general. But I'm wondering what your thoughts are on the congressman's approach to, to focus, or to have a focus in part on Medicaid policy as a strategy to improve overall healthcare.
Yeah, well, the congressman is spot on in terms of what he's focusing on. And I think from a frame of reference, it's actually much more useful to view these new therapies, these gene and cell therapies, much more like an organ transplant rather than a medicine. And insurance will typically pay $500,000, $750,000, million for an organ transplant, and that's essentially what these treatments are. I mean, they're that revolutionary. Now, having all of that cost on you up front, that's the real issue. And so we need to innovate. We have essentially 20th century financing combined with 21st century medicine, and the two are clashing. And if we don't fix that problem, we don't fix that discontinuity, we're going to lose out on all of these really life-changing medicines for so many patients. And so what does that mean? Part of it means we need to be able to finance these costs over time. We need something more innovative, that if I'm getting a lifetime of benefits, I don't pay all those benefits all at once. I mean, when you buy your house services, when you buy a home, you don't pay the entire $250,000 for the house in that year. You do a 30-year mortgage over time. We need that type of financial innovation to help us spread the costs out. We need value-based payments so that if it works 99% of the time, but you're that 1% where it's not working, when you're talking about something that expensive, you shouldn't be paying it. We need better reinsurance so payers and employer plans can spread the costs out over a much wider population. All of these types of reforms are necessary so that the financing can keep up with really what is revolutionary medicine that's going to, I know people like to stay away from the cure word, but cure diseases that have been just awful diseases for many, many years.
So just sticking on this real quick, Wayne, on this question of how to amortize these costs, it seems to me there's sort of two lines of thought on this. One is that when somebody has an experience that requires a treatment that is in the millions of dollars or very expensive, that some people say it's only fair for that person to then stay with the payer, the health plan, the intermediary that's covering those costs for the full benefit, the full life, Yeah, that sort of is in stark contrast to competition itself, particularly having individuals be able to choose their employer or their insurance. So that's kind of a challenge. We want to spread this out over a long time, but people still pick and choose their health plan companies or insurance companies. And I think there's this other question of just like this is all part of the wash and an actuarial analysis over a given 365 days, that maybe that long-term view is not necessary. Where do you think, based on your research, what is a closer fit to how we should think about this? Limiting choice of individuals so that they stay with the health plan, or that this all is essentially, it comes out in the wash in one actuarial year?
I guess I would be a little bit in between. I mean, limiting choice is never the answer, right? So I guess let me start there. When you limit choice, you're not actually helping patients. That's for certain. There are tremendous financial instruments that we have where we offload risk in the financial markets. And so there's no reason that type of financial technology can't come to bear in the health markets. Our insurance system is problematic. So part of the reforms have to address the inefficiencies in our insurance markets. Something which I think we need to try, maybe it's not the answer, but a more efficient reinsurance. I think those types of designs need to be considered. In terms of offloading, not offloading risk, but keeping the costs with the patient. So as they transfer, is there a way that we can use financial instruments so the kind of that cost can be transferred between insurers? I mean, there's all sorts of financial innovation that we can apply, and I don't pretend to be an expert in those areas, but you see it, and there's no reason why we can't apply those solutions to this issue.
Let's go to our next slide here, and this is one that you've brought, Wayne. And before we dig into the details here, can you just give us a quick rundown of the difference between a biologic, what a biologic is, and what a biosimilar drug is as a result?
Sure, and I'll compare that to what traditional medicines, right? Your traditional medicine that you would typically buy at the pharmacy counter is a chemical-based, small molecule medicine, and because it's chemically based, when you have your branded product, when they go off patent, a generic has the recipe, right? So you have the chemical formulation, and it's quite simple, relatively speaking, to create an exact duplicate, a chemical replica of that branded product. Biologics are one of the most innovative medicines that we currently have. These are medicines that are derived from biological processes, whether they're actual biological organisms themselves. They're very complicated to create, and because it's a biological process, right, that biology, you get variation, right, the spice of life, all of those types of things that come from biology rather than chemicals. And so when you have the competitive products, one, it's much more complicated to create a biologic. So even when you have a biosimilar, that process is not going to be as cheap as we're used to when we see the generic competition. But you also are going to have slight variability because these are biological processes. So the competitors are known as biosimilars. And biosimilars are essentially the generic for the biologic. They're competitive products that are significantly cheaper, and when they come in, they reduce costs in the space. But what we're talking about is some of the most innovative medicines. So when you hear about our cancer survival rates improving, we hear all of these drugs that are improving autoimmune diseases or arthritis, all of those are biologics. So biologics are very high value medicines, but they're also high cost medicines.
Yeah. So tell us what you have here in this. It's pretty self-explanatory. It's a great slide, but do you want to speak to it a little bit?
Absolutely. So what I wanted to talk about and bring it to everyone's attention is the idea that competition in the biologic space can work just like it does in that chemical small molecule drugs. Just for reference, about 90% of our the drugs in the kind of that traditional medicine space are generics. They typically cost less than $25 prescription. So those medicines are, generally speaking, affordable. but our affordability crisis, and there is an affordability problem, but it's a tailored problem. And one of the drivers of that are biologics. Again, the high value, treating cancer and the like, but they're also very expensive. Now, it's taken a bit of time for biosimilar market to kind of get its footing here in the U.S. But in Europe, biosimilars have a vast majority of the share in many of the different therapeutic classes. That hasn't yet been the case here in the U.S. And it hasn't, gotten anywhere close to the traditional medicines where 90% are generics. And so we've seen a call for people to say biologics are a natural monopoly, and so competition won't work. And so the idea I wanted to bring up here is that competition not only can work, but it is now beginning to work. We need to continue with policy reforms to make the market stronger. But what we've looked at on the left side of the chart are the prices. So these are the 7 biologic classes where there's currently biosimilar competition. And you can see that biosimilars some of them are more than half off relative to the prices of the biologic before competition. So biosimilars come in and they drop the prices compared to where competition were. And you can also see on the right-hand side of the chart how large of a share these medicines are currently getting. So whereas about 3 years ago, they were de minimis and there was only one biosimilar, it's called Zarcio, it's in the filgrastim class, where they had half the market, and all the others, the biosimilars were basically non-existent, if I can say. Fast forward to 2020, and you can see that we're almost at a quarter of the market on average. Zarcio's and the biosimilars in that class are the majority of the market. So what we're seeing is competition developing, lower cost drugs taking away the market share from the higher cost drugs, and that's actually generating savings. And when you look at what the actual changes in prices are for branded drugs, you can actually see that they're actually coming down on a net basis. So we're seeing competition develop, it's strong, and it's cutting prices, promoting affordability, and that's exactly what we would expect.
So, Congressman, how do you, when someone comes to you in the last few years and says, we've got this, biologic, and now we've got biosimilars, we need to support the biosimilar market, that's pretty sophisticated stuff for a legislator in Congress to have to grapple with, and more about healthcare than most of the other 435 members of the House. So how do you get up to speed on some of these things, and how do you try to make sense of the pace of the innovation? Still got you on mute there, sir. We got you on mute there, Congressman. Yeah. There we go.
Just as well that I didn't say that out loud. I was thinking, well, you need to be sure they have a good staff. Look, the Purple Book Continuity Act, which was passed in 2019, there is a list of biologics that is kept by the FDA, as well as the relevant exclusivity information that pertains to those biologic products. But there was no requirement that the FDA keep that list. So the Purple Book Continuity Act, the Purple Book is where that list voluntarily was housed before. Now the FDA, it's a requirement that the FDA publish updated lists of the biologics that are available and their relative exclusivity information for someone who might be interested in trying to develop a biosimilar. But look, this was part of, we're here sitting right on the cusp of the 11th year of the Affordable Care Act. The period of exclusivity for biosimilars was included as part of legislative language in the Affordable Care Act, but it was not an easy debate. And the period of exclusivity for biologics was the source of some rather fierce negotiations, really inter-party negotiations on the Democratic side. Republicans at the time were in the minority. We only could sort of lend our voices to one side or the other, and Republicans were split on this issue. So historically it has been one that has been a little bit difficult, a little bit contentious. But the good news now with the Purple Book Continuity Act is there is now a formal recitation of the biologics that are available and the relevant exclusivity information that is appended to each biologic. So that now is standard part of FDA practice.
So, Congressman, I want to ask you this question from Patrick Pine, who writes in. He's I believe he's the Chief Administrative Officer for the RFK Health Plan, which is it's not quite, I don't believe it's an ERISA plan, but it's more of, I think, a Taft-Hartley. But nevertheless, they cover farm workers in the Western United States. And he asked this question about whether the federal government could become essentially the stop loss provider for catastrophic cost issues, just as we do for federal flood insurance. Have you thought about having the federal government step in to help cover some of those costs?
Well, in reality, it already is in some instances. And of course, we saw the vaccine development where the federal government actually assured the purchase of a certain volume of vaccines. And this was done prior to whether knowing they were going to be useful or not. So in some ways, the federal government did come in and assure the market, if you will. Now, the good news is the vaccines turned out to be highly effective. And the big question now is, can we produce enough fast enough that people can get them when they want them? But originally, remember, when this was all first talked about in April and May of last year, some concern whether or not there would be any market for a vaccine that was only marginally beneficial. So the federal government said, we will guarantee the purchase of that. Same has been done to some degree with Ebola vaccines. The ability to develop an Ebola vaccine somewhat dependent upon the federal government assuring the purchase for the strategic national stockpile for a certain number of doses. So this, in fact, there is a template to follow here.
Annette, I want to use this as a segue to bring up your slide, because you are specifically talking about biosimilars and you got a lot on here. So why don't I let you walk us through what you've brought to the conversation?
Thank you. When we think about biosimilars, we think about the opportunity for savings for really everybody. And we think about it in terms of, as the Congressman has said, there are small numbers of people who would need to take these, but the savings opportunities are really quite large. So our board challenged us to figure out what the savings opportunities really are. So we took the data from 13 of our member companies across every industry sector, and we teamed with the Johns Hopkins School of Public Health, the doctors Jerry Anderson and Mariana Sokol, who are quite learned in this area. And they looked at the drug spend as well as the medical plan spend, because if you think about it in Medicare terms, that's the Part D plan and the Part B plan. Most biologics are administered, either through a physician or in a hospital setting, and they're billed as part of the medical plan, not as part of the drug plan, which we think about that you might get at your pharmacy or that might be negotiated through a pharmacy benefit manager. And they looked at all of this, and they looked at two particular biologics for which there was biosimilar competition on the market at least a year. Filgrastim, which had already been mentioned, and infliximab. Two different drugs, infliximab more for rheumatoid arthritis and Crohn's disease, and very widely used. So we assumed, what would the savings be if an employer had used the biosimilar 25%, 50%, 100% of the time? So I'm going to give you the 100% of the time numbers. On average, these 13 employers for just these two drugs would have saved almost $5 million a year. That was back in 2018. Imagine what the savings would be now when more and more people are using the biosimilar, because what's happening is that typically patients would be treated first with a chemically based drug, and then they would grade up to a biologic, typically an injectable drug, more costly. And so more and more of the research and development is in biologics. They're more expensive, and the trend is for trading up to these biologic drugs. So we had one company of the 13 that alone would have saved $1.5 million a year, just on one of the biosimilars. And then we looked at what the savings would be for the patients, and they were significant. About 45% less, $600 a year for filgrastim, less than that for infliximab, just because of the way the employer spend is with companies capturing a larger percentage of the cost of that drug. And then we said, is there savings for others? Extrapolating out, the Johns Hopkins folks told us that it was $407 million for a year for, or up to $1.5 billion for all self-insured employers. We can't ignore those numbers, and that the Medicare program had a lot to save as well in the Part B hospital-based program, $300 million almost a year. And we think those numbers are low in what the savings opportunities are. And then we wanted to say, well, what could people do about it? First of all, states have a very big role to play. There are medical societies and the pharmaceutical societies, state legislation that's passed that often puts hurdles in front of the ability of a pharmacist to fill a prescription with a biosimilar, or for a physician to administer a biosimilar instead. We need to look at, if the FDA says these things are approved as safe and effective, they should be able to be prescribed without hurdles in between. And the right side of the slide shows some pieces of legislation that we think the Congress can look at and has looked at as well on a bipartisan basis. It's very hard to get any legislation adopted in the prescription drug space. The Congressman is a great leader in this regard. And so we just wanted to say there's opportunities for savings and there are pathways to actually achieve them.
So are the limits, Annette? I mean, I guess I naively assume that if a drug is available, then a pharmacist or a prescribing physician can make sure that that drug can be accessed, particularly if has the same efficacy and has a better cost. So what are some examples of the hurdles that are in between a biosimilar getting prescribed for patients that don't exist for a biologic?
So there are many. In some states, there'll be a law that says the pharmacist can only fill if the FDA has determined that the biosimilar is interchangeable with its biologic. And there have been no interchangeability designations so far. That's kind of a concept that's more from the generic side than the biosimilar side. There are also requirements that and these are the same hurdles that were thrown up in the 1980s when the Hatch-Waxman Act was first adopted, which created the pathway for generic drugs. First the physician has to check with the pharmacist has to check with the physician. The physician has to say dispense as written. Things like that are just some administrative hurdles that protect the biologic maker for protecting their market share for a longer period of time. There's also, I think, misnomers and misinformation out there about the challenges for switching a patient from a biologic to a biosimilar. A lot of people fear that there's some safety challenges with those. We think that that's more overblown than perhaps is warranted.
So, Congressman, as you think about easing or lowering hurdles for biosimilar adoption, do you see this as mostly a federal issue or mostly a state issue? And I would think that ambiguity and complexity makes solving this even more difficult.
Yeah, well, and of course, on the federal side, it's a regulatory issue as well, because the comparison on the small molecule on the generic drug space is very appropriate. And remember, it was under the leadership of Scott Gottlieb at the FDA that he really accelerated. Generic drugs have been around for years and years, and he really accelerated the approval of new generics with a significant cost savings to consumers, such that the Trump administration was able to claim an actual lowering of the drug spend in the first 2 years of the administration. So that was a phenomenal achievement. And is the same phenomenon capable, or is it expectable in the biosimilar and biologic market? I believe that it is, and certainly the pathway is there for the approval of the biosimilars. Some of it is going to be educating the clinician, the doc, that this is this is going to be a reasonable path for you to follow, and some of it's going to be patient acceptance. You can well imagine that it might be difficult to get a mother to accept a different a prescription for her child than the one that has worked so well for a number of years. So all of those are going to be barriers or obstacles to the advancement.
I want to go to our last slide here, and I recognize we are starting to get a little bit short on time, so I don't want to dwell on this too much. This is a question or a slide rather that we contributed to this conversation, and it shows essentially the public opinion across a range of questions, which pretty strongly are reflective of public opinion wanting action on affordability and access to new and existing prescription drugs. And so my question really is just to you, Congressman. I'll let you sort of take this and educate us all. Why is pharma and pharmacy policy at the statutory, at the congressional level, why is this such a challenging topic that we continue to wrestle with?
Back in December of 2017, I had a supply chain hearing to actually dig into this very question. And look, it's no secret. The prices of insulin, the prices of the EpiPen, the consumer prices of those products really have just driven the public crazy in the last, they've really commanded public opinion in a way that really hasn't been seen before. And my encouragement to both the PBMs and the hospitals and the pharma companies was, you've got to pay attention to this. We can't tell you exactly what you need to do, but you need to help us come to a conclusion that is actually doable. Because if you don't, then people are going to demand that something be done, and what may be done may be something that you don't particularly care for. But unfortunately, I really didn't get very far with having that discussion, and the consequences are that we see bills like H.R. 3 in October of 2019, where it was a 95% excise tax that the Pelosi Democrats wanted to impose on new breakthrough drugs. Well, wow, you wouldn't want to do that right before you started a pandemic, would you? But in fact, the House did pass that. Fortunately for us, the Senate never did.
I know we could spend a lot of time geeking out on RX policy. At least I can spend a lot of time. I expect the three of you could as well. As we near the end here, I want to ask each of you this question. I'll start with you first, Wayne. As you look out on 2021, and we all hope that it's better than the last 12 months, let me just ask you, either personally or professionally or both, what gives you hope for the rest of 2021?
I think the thing that gives me the most hope are the vaccines. And I think that hope is both professional and personal. I mean, we can, with more, we're at what I think 25% have had at least one dose of the vaccine. So we're really moving along very well. We'll be able to go back and do activities that we want. So personally, kind of re-engage in a broader aspect of our lives. For the economy, I actually fear for 2022 because of all the things we're doing right now. But in the near term, the economy is going to start doing better. People will feel better. We're gonna, this pall that's been hanging over us is going to lift, and so I think that in the short term is optimistic. I'm going to keep this optimistic and not worry about the longer term implications. That's a whole different 5-slide discussion. But all of that gives me, makes me feel better that things will start returning to normal.
We're trying to end on an uplifting note, so I appreciate that, Wayne. Yeah. Annette, how about you? What gives you hope as you look out on 2021?
Well, certainly the vaccines. I think that, and also the glimmers of hope for bipartisanship through whether it's the Problem Solvers Caucus or leaders like Congressman Burgess, who will be able to reach across the aisle and work on solutions that the country would benefit from significantly. So one of the things I'm hopeful for is that when we're finally allowed to get together in big rooms again, that groups of Republicans and Democrats get back to getting to know each other better, learning from each other, and accepting, I work for Senator Dole, and 80% of the loaf is sometimes good enough, and I just think we need more leadership in that regard, and I'm hopeful that the pandemic is going to bring us to a wave of bipartisanship.
Finally, Dr. Burgess, what gives you hope as you look out on 2021?
Well, like everyone else, I mean, the vaccine story for this past year has really been phenomenal. It's been remarkable. But I also, the cautionary note, I don't know exactly how many emergency use authorizations were required for the FDA to give to get us through this pandemic, but I suspect it was in the hundreds. And I guess the question as a policymaker is, if you have an agency that is requiring, where you require hundreds of emergency use authorizations to survive a pandemic, the question may not be under regulation. So I do hope we'll look at some of the things, perhaps at our regulatory agencies, that were not helpful in getting us to this point where we may now recover from the pandemic.
Very good. Congressman Dr. Michael Burgess, member of the Energy and Commerce Committee. Sir, thanks for being with us. Annette Gorisco-Fields, the president and CEO of the ERISA Industry Committee, and Dr. Wayne Weingarten, PhD, senior fellow and director at the Center for Medical Economics and Innovation at the Pacific Research Institute. Thank you all for being with us, and for our audience, thanks for being with us. We will have this posted at stateofreform.com, and we will have more conversations like this at our 2021 State of Reform Federal Health Policy Conference on April 7th and 8th coming up. Thanks, and we'll do this again soon.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.